Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text.
Welcome to the deep dive. Today, we are acting as your personal guides through Chapter 22 of the Guyton and Hall textbook of Medical Physiology, the 15th edition.
Which is just a fantastic chapter, really.
Oh, it's incredible. And our overarching mission for this conversation is to take some incredibly dense, complex cardiovascular mechanics and translate them into plain, accessible language.
Right.
So if you are a college student tackling medical physiology for the first time, or just someone fascinated by how the human body works, you are in exactly the right place.
Yeah, and it's a brilliant chapter to dive into because the textbook lays everything out in this perfect logical chain. Mm-hmm. We are going to explore how an initial change in anatomy, alters the heart's function, and then how the body's nervous system and the kidneys attempt to regulate and fix that drop in function.
Right, the regulation phase.
Exactly.
Yeah.
And finally, how those integrated systems lead to the physical outcomes a patient actually experiences.
Which brings up something I've always found just totally mind-blowing. When you picture a failing heart, you probably imagine like an engine just sputtering out.
Yeah, like a mechanical pump that simply stops working.
Exactly. But the real danger in heart failure, the thing that often becomes lethal, is actually the body's own frantic attempts to save itself.
It's the profound irony of human physiology. I mean, the very survival mechanisms designed to keep you alive in an emergency are frequently what ultimately ground the body in fluid.
Wow. Well, let's unpack how that happens, starting from the very first moments of an acute strike. So picture an acute myocardial infarction, a heart attack.
Right.
A coronary artery is blocked, blood flow to the heart muscle stops, and the tissue is instantaneously damaged. Because function follows anatomy, the heart's pumping ability is immediately depressed.
Yeah, and you see two instantaneous effects there. Reduced cardiac output and blood damming up in the veins. To really understand the severity of this, we need to visualize the textbook's famous cardiac output curve. So, if you imagine a blank graph in front of you, the horizontal axis along the bottom is right atrial pressure.
Which tells us how much blood is backing up into the heart, right?
Exactly. And the vertical axis going up is cardiac output, so how many liters of blood the heart is actually pushing out into the body per minute.
Okay, so on a normal day, a healthy person is operating at a very specific point on that graph. You are sitting at a normal cardiac output of 5 liters per minute, and your right atrial pressure is 0 millimeters of mercury.
Right. Everything is perfectly balanced.
But immediately after that heart muscle is damaged, that operational curve just drops off a cliff.
It really does. Within just a few seconds, cardiac output plummets from 5 liters a minute down to a dangerous 2 liters per minute.
Wow.
And because that blood isn't being pumped forward into the arteries, it has nowhere to go but backward. It dams up. Yeah. Your right atrial pressure rises from 0 up to plus 4 millimeters of mercury.
And living on 2 liters a minute is terrible. Your brain and tissues are suddenly starving for oxygen. You would be dizzy, potentially fainting, and incredibly short of breath.
Oh, absolutely.
But the body doesn't just sit there and accept defeat, right? We enter a phase the text highlights as the acute compensation, which we could call the 30-second rescue. Almost immediately, the sympathetic nervous system kicks in through the baroreceptor reflex.
Yeah, and the speed of that reflex is just incredible. You have these specialized pressure sensors. Yeah. The baroreceptor is located in the carotid arteries of your neck and in your aortic arch.
Okay.
The moment they feel that arterial pressure drop, because the cardiac output fell to 2 liters, they fire off distress signals to the brainstem.
And the brain responds by basically blasting sympathetic nervous signals down to the heart and the blood vessels.
Precisely.
I love visualizing this like a rowing crew. Imagine a boat where half the rowers suddenly drop their oars because of the heart attack.
Right, the damaged tissue.
Exactly. The sympathetic nervous system is like the coxswain sitting in the back who immediately starts screaming through a megaphone for the remaining healthy rowers to row twice as hard.
That's actually a highly accurate way to look at it. The sympathetic stimulation does 2 crucial things. First, just like your coxswain, It forces the undamaged heart muscle to contract much harder and faster, compensating for the dead tissue.
Makes sense.
Second, it constricts the peripheral blood vessels, particularly the veins.
Which is so important because clamping down on those veins raises something called the mean systemic filling pressure.
Yes.
Basically, it physically squeezes the blood that's resting in your veins, forcing this massive surge of blood back into the heart to aggressively prime the pump.
And that aggressive priming works. On our mental graph, this sympathetic rescue pushes our operating point higher.
Okay.
The right atrial pressure nudges up even further to 5 millimeters of mercury because of that extra squeezed blood. But the cardiac output jumps back up from 2 liters to 4.2 liters per minute.
And that 4.2 liters per minute is a life-saving output. It's enough to keep you conscious and keep your organs alive. It buys the body precious time.
Exactly.
But the text makes it very clear this is only a temporary acute fix. Moving from the timeline of seconds and minutes into hours and days, we enter the chronic stage.
Right, the longer term.
Yeah. The sympathetic nervous system is blazing, but the heart is still fundamentally weak. So the kidneys jump in to help regulate the system by actively retaining fluid.
They hold on to sodium and water, reducing your urine output to almost nothing, which steadily increases your total blood volume.
Okay, I actually want to push back on the logic of this because it feels completely backwards when you first read it.
It really does.
Right. Like, if the heart is a damaged, struggling pump, why on earth would the kidneys add more fluid volume to the system? Isn't that just giving a weak pump more heavy lifting to do?
It sounds like the worst possible strategy. But looking at the physics of venous return, moderate fluid retention is actually highly beneficial in the early stages.
Wait, really? How?
Well, by increasing the total blood volume, the kidneys further increase that mean systemic filling pressure we just talked about. You are creating a much stronger pressure gradient to physically drive blood toward the right atrium.
Oh, I see. And it also distends the veins. Like, if the veins are physically wider because they are full of fluid, venous resistance drops, making it easier for blood to slide back to the heart.
Precisely. You are optimizing the preload, stretching the remaining healthy cardiac muscle fibers just enough so they contract with the maximum possible force.
That's the Frank Starling mechanism, right?
Exactly. And over a few weeks, with this extra fluid volume and a little bit of natural tissue recovery, the cardiac output can actually return to the normal 5 liters per minute while you are resting.
But the trade-off is that your right atrial pressure remains permanently elevated, sitting at maybe 6 millimeters of mercury instead of 0.
Right.
This is a massive concept in the text known as compensated heart failure. A patient with compensated heart failure might be sitting across from you reading a book, and you would have no idea they suffered major cardiac damage.
Because their resting output is normal.
Exactly.
Underneath the surface, though, the system is operating under immense stress. The heart is still on a depressed functional curve. It is just being artificially pushed up to a normal output by these elevated filling pressures.
Which begs the terrifying question. What if the anatomical damage is simply too severe? What if the heart is so destroyed that no amount of sympathetic squeezing or kidney fluid retention can get the output back to normal?
That brings us to the tipping point, decompensated heart failure.
Okay, walk me through that.
If we go back to our Mendel graph, imagine a solid horizontal line drawn exactly at the 5 liters per minute mark. That line represents the critical cardiac output level.
Meaning?
It is the absolute minimum blood flow the kidneys require to function normally and excrete the water and salt you take in every day.
So if the cardiac output is stuck at, say, 4 liters per minute, it never crosses that critical horizontal line.
Right.
The kidneys are permanently underperfused. They basically think the body is severely dehydrated or bleeding to death.
And because they think the body is bleeding out, they never stop retaining fluid. The blood volume keeps rising day after day.
Wow.
The venous return curve shifts dangerously to the right. The body becomes completely overloaded with fluid.
It's the ultimate fatal feedback loop. I picture it like a sinking ship where the internal bilge pump is badly damaged.
That's a good way to picture it.
Right. And the ship's automated computer sees the pump struggling and decides the solution is to open the external valves and let more ocean water in to cool the pump down. The heart just becomes completely overstretched.
Yeah, and that overstretching is a key physiological failure. When the heart muscle fibers are stretched too far by all this excess fluid, the actin and myosin filaments inside the muscle cells get pulled so far apart that they can no longer grip each other effectively.
So the heart's pumping strength actually drops as it gets wider.
Exactly.
So the output falls even further, which makes the kidneys hold on to even more fluid, which stretches the heart even more. Without intervention, this decompensated state inevitably leads to death.
That's grim.
It really is. But the textbook does outline how modern medicine breaks this cycle, specifically using inotropic drugs like digitalis or digoxin. I want to try explaining the cellular machinery here because it is just wild how targeted this is.
Go for it. The cellular mechanism is one of the most elegant concepts in the chapter.
Okay, so digitalis works by poisoning a very specific protein on the cardiac cell membrane called the sodium-potassium ATPase pump. Normally, this pump uses energy to aggressively push sodium out of the cell.
Right.
By inhibiting it with the drug, sodium can't get out, so intracellular sodium levels start to build up.
And that buildup is the master key because it sabotages a second pump on the membrane, the sodium-calcium exchanger.
Right. The exchanger normally relies on a really steep sodium gradient, lots of sodium outside, but very little inside to power its job of dragging calcium out of the cell. But since digitalis caused sodium to build up inside, that gradient is gone. The exchanger slows down, and as a result, calcium gets trapped inside the cardiac muscle fibers.
And tying that back to fundamental muscle physiology, calcium is the trigger for contraction. Extra intracellular calcium binds to troponin, exposing more actin binding sites, allowing for massive cross-bridge cycling.
So it creates an incredibly forceful contraction.
Exactly. This positive inotropic effect strengthens the failing heart just enough to push the cardiac output above that critical 5-liter line, which finally allows the kidneys to excrete the deadly excess fluid.
It's amazing how a microscopic change in a cell membrane pump translates to draining liters of fluid from the entire human body.
It really is.
Speaking of fluid, let's talk about where all that excess water actually goes and look at how these integrated systems behave. The text brings up a really counterintuitive fact. If you have an acute heart attack today, you do not get swollen ankles today.
Right. Acute heart failure doesn't cause immediate peripheral edema.
Yeah, which is a common misconception, but the physics of the circulatory system explain why. When the heart acutely fails as a pump, it stops moving blood from the venous side to the arterial side.
Right, the forward flow stops.
As a result, the high-pressure arterial side, the aortic pressure, rapidly falls. Meanwhile, the low-pressure venous side, the right atrial pressure, rises as blood dams up.
They basically meet in the middle. The textbook notes they reach an equilibrium at about 13 millimeters of mercury.
Okay, so because of that equilibrium, the pressure inside your peripheral capillaries, like the tiny vessels in your legs and arms, actually drops initially.
Exactly. It falls from a normal 17 millimeters of mercury down to 13. Since the capillary pressure is lower, fluid is absolutely not being pushed out into the tissues.
So to get those swollen ankles peripheral edema, it takes days. You have to wait for the kidneys to activate their slow, long-term fluid retention pathways.
Right, specifically the renin-angiotensin-aldosterone system, or RAS.
Yeah, to build up enough shear volume to force fluid into the tissues. But the textbook makes a terrifying distinction when it comes to unilateral left heart failure. When only the left side of the heart fails, the timeline for edema is vastly accelerated, and it happens in the lungs.
This is one of the most critical integrated outcomes in the text. Imagine the right side of the heart is perfectly healthy, but the left side is severely weakened by a localized heart attack.
Oh, okay.
The healthy right heart keeps pumping blood into the pulmonary circulation into the lungs at full force. But the weak left heart cannot pump it out into the body fast enough.
So the blood has a massive traffic jam specifically inside the lungs.
Right. The pulmonary capillary pressure skyrockets. The textbook points out a magic number here, 28 millimeters of mercury.
And that 28 millimeters of mercury is the colloid osmotic pressure of the blood, right?
Exactly. And if the pressure exerted by the plasma proteins, mostly albumin, that act like microscopic sponges, holding water inside the blood vessels.
Okay.
As long as the physical blood pressure pushing outward is lower than 28, the sponges keep the fluid inside.
But the moment that pulmonary capillary pressure gets pushed above 28, the physical pressure overpowers the sponges. Fluid aggressively filters out of the capillaries and floods directly into the lung tissue and the air sacs, the alveoli.
Which is acute pulmonary edema. And the vicious cycle it triggers is just a nightmare.
It feeds on itself almost instantly, doesn't it?
Oh, absolutely.
Think about the cascade. Fluid fills the air sacs, so the blood can't pick up oxygen. The body detects this severe lack of oxygen, which stresses the heart even more.
Right.
But crucially, low oxygen causes your peripheral blood vessels to massively dilate. That vasodilation causes a huge rush of venous blood back to the right side of the heart.
And the healthy right heart does what it's supposed to do. It pumps all that extra blood straight into the pulmonary artery.
Which drives the pressure in the lungs even higher.
Exactly, forcing even more fluid out into the drowning air sacs. It accelerates so rapidly that patient can die of suffocation in 20 to 30 minutes without emergency intervention.
To break that cycle, you have to hit it from multiple angles. Emergency medicine uses pure oxygen to combat the desaturation, rapid loop diuretics like furosemide to force the kidneys to aggressively dump fluid, and blood pressure medications to reduce that venous return. Spot on. So we've covered the acute crashes and the chronic fluid overloads. Let's look at how doctors actually test the limits of a compensated heart. The textbook spends time on a concept called cardiac reserve.
Yeah, cardiac reserve is simply the maximum percentage that your cardiac output can increase above its normal resting level.
Okay.
A healthy young adult has a reserve of roughly 300 to 400%. That means if you start sprinting, your heart can pump 4 times as much blood to meet your muscles' demand. An elite athlete might even hit 600%.
But a patient with severe heart failure has 0% reserve. This ties perfectly back to what we discussed earlier with compensated heart failure.
He does.
We established that a compensated patient looks completely fine resting in a chair because their kidneys boosted their blood volume to get their resting output back to 5 liters per minute.
But the moment you put that same patient on a treadmill for an exercise stress test, the illusion shatters.
Right.
Their heart is already working at its absolute maximum capacity just to maintain that resting state. It cannot increase its output any further.
So they immediately hit 0 reserve.
Exactly, resulting in extreme shortness of breath, a racing heart rate, and severe muscle fatigue because the tissues are instantly starved of oxygen.
Now, when we talk about a failing heart, we usually picture a weak, floppy balloon that can't squeeze properly. In medical terms, that's measured as a reduced ejection fraction.
Yes.
The ejection fraction is just the percentage of blood pumped out of the ventricle, with each beat normally about 50 to 70%. But I want to explore a paradox the text brings up. Heart failure with preserved ejection fraction, or HFpEF.
It is a phenomenal clinical puzzle.
Right. If the ejection fraction is completely normal, say, the heart is successfully pumping out 60% of the blood it holds with every single beat, how can the patient be in heart failure?
The textbook beautifully illustrates this using pressure volume loops. In HFpEF, the fundamental problem isn't that the heart muscle is weak.
Okay.
The problem is that the heart muscle has become incredibly thickened and stiff, a condition called concentric hypertrophy. This is often the long-term result of chronic high blood pressure.
Oh, I see.
Yeah, the heart had to build so much extra muscle to pump against that high pressure that it physically changed its geometry.
I try to picture this using a nightclub analogy. Think of a normal heart like a massive, spacious nightclub. But in HFpEF, the physical walls of the club have been heavily reinforced with thick concrete. That's the muscle hypertrophy.
Right.
The bouncers are doing their job perfectly. They successfully kick out 60% of the patrons every hour. That's your preserved 60% ejection fraction.
But because those concrete walls are so incredibly thick and stiff, the inside of the club, the actual ventricular chamber, has shrunk drastically. It won't relax and stretch to let people in.
Exactly. So even if you kick out 60% of the people inside, the absolute number of people leaving the club is tiny because the room was practically empty to begin with.
The end diastolic volume is drastically reduced. So even with a mathematically normal 60% ejection fraction, the absolute stroke volume, the actual milliliters of blood pumped per beat, is simply not enough to meet the body's metabolic needs.
And as a result, the left atrial pressures skyrocket as blood tries to force its way into this stiff chamber.
Exactly, leading to the exact same symptoms of fluid backup and shortness of breath.
It goes to show that heart failure isn't just one monolithic disease, it's a deeply complex syndrome. And speaking of edge cases, the text poses one more brilliant question. Can the heart fail while pumping more blood than normal?
Surprisingly, yes. This is classified as high-output heart failure. The textbook outlines 2 bizarre physiological scenarios where the cardiac output is far above the normal 5 liters per minute, yet the patient is technically in heart failure because the heart is overloaded.
The first scenario is an AV fistula. This happens when there is a direct short circuit between a large artery and a large vein. Normally, arterial blood has to squeeze through a massive network of tiny, high-resistance capillary beds before making it back to the veins.
But an AV fistula bypasses those capillary beds entirely. The high-pressure arterial blood dumps directly into the low-pressure venous system. Systemic vascular resistance absolutely plummets.
Which causes a massive, immediate venous return that floods into the right atrium.
Exactly, essentially overloading a perfectly healthy heart. The heart has to pump at near maximum capacity just to keep up with the tidal wave of returning blood, leaving zero cardiac reserve for anything else.
The second scenario is beriberi, which is a severe deficiency of vitamin B1 or thiamine. The mechanism here is fascinating because it's a double blow to the system. Thiamine is essential for cells to produce ATP, their fundamental energy currency.
Without ATP, two things happen simultaneously. First, the heart muscle itself is starved of energy, severely weakening its pumping ability and depressing the cardiac output curve.
Okay, that makes sense.
But second, the smooth muscles lining your peripheral blood vessels also lack the energy to maintain their normal tension.
So the blood vessels all over the body just relax and dilate. Resistance drops and you get that same massive tidal wave of venous return crashing into the heart. But this time, it's crashing into a heart that is already fundamentally weakened by the lack of ATP. The heart pumps furiously, resulting in a high total output compared to a normal person, but it's still not enough to clear the massive volume of blood returning to it.
Exactly, leading to fluid retention and high output failure. It is the perfect illustration of how anatomy, function, and regulation are inextricably linked.
It really is.
And understanding these intricate neurohumoral mechanisms is exactly how modern medicine treats heart failure today.
It really all clicks together. We use ACE inhibitors to block the renin-angiotensin system, forcing the kidneys to stop holding on to salt and water. We use medications that block aldosterone to prevent fluid buildup and stop the heart muscle from getting stiffer.
Yeah.
And the text even highlights SGLT2 inhibitors, drugs originally developed for diabetes that turn out to work magic in both reduced and preserved ejection fraction heart failure by fundamentally improving the heart's metabolism and promoting fluid loss.
Every intervention is designed to interrupt the logical chain we followed, trying to mitigate the anatomical damage, supporting the pumping function, and strictly controlling the body's regulatory systems before they cause decompensation.
Which leaves us with a final, slightly provocative thought to mull over. The entire tragedy of heart failure isn't just a mechanical pump breaking down. It is a profound evolutionary mismatch.
The body misinterpreting the crisis.
Think about human evolution. For millions of years, if your cardiac output suddenly dropped, it wasn't because a microscopic plaque ruptured in your coronary artery.
Right.
It was because a tiger bit your arm off and you were bleeding to death. The body's ancient, hardwired survival mechanism for a drop in blood pressure is to assume you are bleeding. It clamps down the blood vessels, spikes the heart rate, and commands the kidneys to hoard every single drop of water.
It deploys a trauma response.
But today, during a modern heart attack, there is no blood loss. Yet the body panics and deploys those exact same archaic weapons. It clamps the vessels and hoards water, increasing the workload on a failing, overtaxed heart until it is completely destroyed.
It's tragic, really.
If we could somehow selectively mute the kidneys during a heart attack and tell them, relax, we aren't bleeding, the heart might just have the space, the low pressure, and the peace it needs to heal itself.
It completely reframes how you look at patient care. You aren't just fighting the disease, you're fighting millions of years of evolutionary programming that is trying to help, but is actually making things worse.
Absolutely. And on that note, from all of us at the Last Minute Lecture team here at the Deep Dive, we want to extend a warm thank you for joining us. We hope this exploration brought Chapter 22 of Guyton and Hall to life, and we wish you the absolute best of luck with your medical physiology studies. Keep connecting those dots.